Hello, my name is Maureen Murray. I'm the Vice President of Clinical Programs here at Curana Health. I'm excited to have the opportunity to talk with you today about our utilization management program and authorizations. So what is utilization management? Utilization management is a department tools that the health plan uses to ensure that members receive the right care at the right time in the right setting through clinically grounded medical necessity reviews. Our goals are to deliver effective treatment, protect benefits while managing costs, and improve health equity and maintain CMS compliance, ultimately reducing barriers to care and elevating the well-being for the population that we serve. All of the decisions, determinations, and programs, benefits, services that the health plan offers is grounded in the medical necessity requirements of CMS. As you can see below, CMS defines medical necessity as healthcare services or supplies needed to prevent, diagnose, or treat an illness, injury, condition, disease, or its symptoms, and that meet accepted standards of medicine. One of the ways that the health plan ensures that medical necessity guidelines have been met, as well as members receive the right care at the right time in the right place, is through our authorization process. Some general authorization guidelines to know is that if a member needs a service or procedure listed in the authorization requirements grid, the provider must obtain that authorization within the time frame indicated on the authorization grid. Failure to obtain the authorization in advance will result in a claim payment and potential provider liability denials. Referrals are not required for members to see specialists within the plan network, and members may directly access those services as part of their plan benefits. So if someone needs to see an orthopedist or a urologist or a hematologist, you do not need to get a referral and authorization to go and see that provider in the clinic. If there's a procedure that they are going to do, the specialist, there could be an authorization requirement upon that. But to see the physician or to see that specialist, you do not need a referral or an authorization. And then the plan's website includes documentation or documents that outline the services that require authorization. It also provides forms and other helpful resources on the authorization process here at Curana Health. review types. For standard reviews, CMS allows up to 72 hours for Part B medications, up to 14 days for all standard authorizations, retro or concurrent, and 7 days for prospective. As you can see on the slide, it says up to 7 and 14 days, but normally it does not take the team that long. Goals are to return authorizations and complete the reviews within 4 to 5 days. Concurrent review is a process where the plan reviews to see if the additional days requested are medically necessary for a service, such as a skilled nursing service, skill in place, or inpatient hospital. Expedited review requests are reserved for instances where waiting for a decision under the standard review timeframe could place the member's life, health, or ability to gain maximum function in serious jeopardy. A decision for expedited reviews must be returned within 24 hours for a Part B medication or within 72 hours for all other expedited authorization requests. Prospective reviews, better known as prior authorizations, are specific requests that need a review conducted prior to a member's admission, stay, or service or treatment rendered. Retrospective reviews are conducted after the services have been provided to the member. When is an authorization needed for a Part A service? For urgent, emergent, acute care hospitalizations, prior authorization is not required before the member is sent to the emergency department for treatment and stabilization. The acute care facility or hospital should request authorization within 2 to 3 days of the member's admission. For non-urgent acute care facilities, requests such as LTACs and inpatient rehab facilities, prior authorization is required before a member is able to be transferred to one of these non-urgent acute care settings. For post-acute SNF admissions, a prior authorization is also not required before the start of the SNF episode. When the member is discharged to an in-network nursing facility from an inpatient hospitalization. The hospital should review with the facility clinical staff to determine whether the member is appropriate for that increased level of care, SNF services, and if so, place the order for the skilled nursing services. After the skilled nursing services are started, the SNF authorization requests, including supporting clinical documents, must be submitted to the department within 2 to 3 days of the start of the SNF services. Skill in place allows a member experiencing an acute and sudden change in their condition to receive an elevated level of care and skilled services in their home nursing facility. This allows the member to utilize their Part A benefits and receive the treatment they need while avoiding an unnecessary hospital admission when the nursing facility is able to provide that skilled care. The plan does not request an authorization prior to the start of the SIP services, the skill in place. However, skill in place authorization requests must be received by the department within 1 day of the start of the SIP services. Now that we've reviewed the Medicare service types and best practices, let's further review the authorization process. The Utilization Management Department handles all authorization requests for Part A and Part B services. This slide provides high-level overview of the authorization process. When a member requires services, the first step is always to review if an authorization is required. If required, submit the authorization request. Next, the clinical team will review the service request and complete a medical necessity review. Once the team review is completed, the clinical team will provide the decision letters and notification to the member and provider. Let's look at each step in a little bit more detail. How to know if an authorization is required. You can navigate to the health plan's website, where under For Providers, there is a Utilization Management Authorization tab. The listing of services that require prior authorization can be found on this site. Please refer to the documents, Services Requiring Authorizations. You can find one at a higher level, as exampled to the right, or there is also a spreadsheet that's available that goes down to the code level to determine if an authorization is required. How can you submit authorizations? There are 3 ways: provider portal, the fax, or the phone. The provider portal, you can enter that authorization request directly into the portal and see the status of the request submissions through the provider portal. Requesters can also fax the authorizations form and clinical documentation to the plan's fax number, or the requester may call the plan phone number with the request to provide verbal clinical information. Please note, if you do call in and provide verbal clinical information, we do require the written clinical information to be faxed in prior to a decision being rendered. The provider portal. The provider portal is really the gold standard method to submit the authorization request. The provider portal is an automated, user-friendly way to initiate an authorization for services, check on the status of an authorization, and send the clinical documentation and request additional service days. Once registered, you can access the portal from the plan's website. You will find the provider portal login link under the For Providers tab. Please review the provider portal training module for complete information on how to submit and view the status of authorization requests. What information is needed for an authorization? The following information is required for a determination: member name, member ID, location of service, physician's name, requesting provider name, servicing provider name, date of service, diagnosis, procedure code, and clinical information. I cannot stress enough how important the clinical information to support the need for the service to be rendered is in the determination process. If you do not submit that information, your request may be denied based upon lack of information. You can also find forms that will help outline and specify the information needed for your request. You can find these forms on our website at the path below. What happens in the clinical review process? The clinical review team documents and evaluates the request received from the provider portal, fax, and/or phone. They then evaluate the requests against evidence-based guidelines to ensure that services requested are medically necessary and clinically appropriate. In order to do this, they utilize the CMS guidelines, including NCD, LCD, and manuals, and if there's none available, then we'll use the MCG guidelines to determine if the request is medically necessary and clinically appropriate. All of these evidence-based guidelines are reviewed and approved annually by our Utilization Management Committee. The UM team will make every effort to make outreach and notify if the clinical documentation is needed to approve the request. If any necessary information is not included in the request, the authorization may be delayed or denied in the determination process. Once an authorization decision has been made, members and providers are notified. If approved, a notice of authorization is issued, which will notify the provider and member that requested services have been approved. There are two main types of adverse determinations or denials. An administrative denial occurs when the authorization request did not meet one or more of the administrative requirements, such as late notification, missing or incorrect demographics, or benefit exclusions. Medical necessity denials occur when requested services do not appear to meet medical necessity criteria based on the clinical information submitted to the plan, or cannot be validated based upon the information provided. Please note that all medical necessity denials are determined and completed by the plan's medical director. Once a denial has been determined, the plan medical director will reach out to the member's requesting provider to offer a peer-to-peer discussion. This will occur prior to administrating a medical necessity denial. So in conclusion, a couple of items to remember on the authorization process. Please go to the plan's website that offers access to our resources. Make sure to request the services under the appropriate member's benefit, keeping in mind that Part D services or drugs are reviewed by a different group. The provider portal is the gold standard in submitting authorization requests. Most authorizations are requested under the standard priority time frame. However, expedited reviews could be requested and should be reserved for instances when waiting for the decision under the standard time frame could place the member's life, health, or ability to gain maximum function in serious jeopardy. For urgent requests, a verbal clinical can be provided to the UM clinical staff, but the written documentation must be received prior to that determination being made. Now let's review skill in place services in a little bit more detail. What is skill in place services? These are skilled services that are provided in a skilled nursing facility in place of an inpatient hospitalization by waiving the 3-day hospital stay requirement. By providing these skill-in-place services, we're minimizing transitions outside of the facility. We're preventing avoidable hospitalizations when appropriate. But it does require a skillable need in combination with meeting the skill-in-place criteria. What is the difference between skill-in-place and skilled nursing facility? Skill-in-place services are an alternative to a hospital admission. It requires a skilled service needed to be present for the member. However, skill-in-place minimizes transitions outside of the facility by waiving the 3-day hospital requirement. Skilled nursing facility services should be requested after an inpatient hospital stay. Members returning from a hospital admission, observation services, or emergency room should be considered for the post-acute Part A services. Let's look at the definition of what is a skilled service. A skilled service requirement that doctors or other healthcare providers has ordered daily skilled care, and that care is provided from or under the supervision of a skilled nursing or therapy staff. Examples of skilled services include oxygen, IV antibiotics or fluids, complex wound care, or other care that is new and requires an RN or LPN to provide that service. Please note that isolation is not required a skilled service. When considering if skill-in-place is appropriate, follow CMS guidance for skilled nursing facility level of care. Skill-in-place services are covered if all of the following 4 factors are met. The member must require a skilled nursing service or skilled rehab service. They must require these skilled services on a daily basis. The daily skilled service can be provided only on an inpatient basis in a SNF. And the skilled services are reasonable and necessary for the treatment of their illness or injury. Here are some potential skill-in-place conditions. Pneumonia or COPD exacerbation requiring oxygen and daily intervention and observation by nursing or rehab. Heart failure requiring IV and IM diuretics or oxygen. Skin infection requiring IV antibiotics and complex wound care. Severe dehydration requiring IV fluids. UTIs requiring IV antibiotics. And symptomatic COVID-19 requiring IV fluids or oxygen therapy. There are also other qualifying conditions as approved by the Plan Medical Director. Please be sure to use that clinical judgment to determine if a member is appropriate for the skill-in-place services. Based upon the 4 factors that we learned in the previous slide. Let's talk about the skill-in-place general process. The member will experience an acute change in condition. The change in condition is documented by the facility nursing staff and reported to the provider. The provider will confirm the skilled need via a face-to-face or telephonic assessment. Provider will order the skill-in-place services, specifically documenting diagnosis, plan of care, including the skilled need and daily need of care, and the initiation date and duration. The nursing facility may now start the skill-in-place services once the order has been placed, but within 1 calendar day, the designated facility staff would submit the authorization request to the plan with the SIP orders and clinical documentation from the start of the services. You must include documentation supporting the daily need of care, as well as that the care is reasonable and necessary for the treatment of the member's illness or injury. The department clinical review is completed and the decision is communicated to the facility, ordering provider, and member. Once approved, the member assessments completed by the provider are completed periodically to extend or terminate the skill-in-place services. Reassessment and ongoing treatment of the skill-in-place services. So the initial skill-in-place service duration may be up to 7 days, depending upon the skilled need, condition, and diagnosis. Either the APP provider will reevaluate the member, and it should occur no later than 2 days prior to the last covered day, but may occur up to daily. Reevaluation recommendations is 1 to 2 provider assessments within a 7-day skill in place episode. Additional skill in place days must be requested no later than 2 days prior to the last covered day with the following information: additional written orders, the current APP PCP assessment with the supporting clinical and clinical documentation to support that daily skilled need, and the member's treatment plan. Please keep in mind these considerations for skill in place services. Skill in place services do qualify as a Medicare Part A benefit, which has a limited number of treatment days during a benefit period and only 60 lifetime reserve days. Let's make sure it's in the member's best interest to use these benefit days for circumstances when a Part A skilled need is warranted. Skill in place services can be used when a new demonstrated skilled need is present and intended for the acute phase of an illness only. SIP services may be initiated without receiving a prior authorization, but the service request, physician orders, and supporting clinical documentation must be submitted to the plan as soon as possible, preferably within 1 calendar days after initiation. Your initial service authorization may be up to 7 days depending upon condition and diagnosis. Additional skill in place days must be requested no later than 2 days prior to the last covered date of service and include new written orders, supporting clinical information including the provider face-to-face reevaluation, and clinical notes supporting the daily need of care and members' treatment response and update. And again, if you have any questions regarding skill in place services, please go to your health plan's website. Thank you.